Okay. So like I was saying, with chapter 31 and 33 for male and female reproductive disorders, it's basically just knowing the terms, what they are, okay, and that's basically it. We're going to take the material be a little lighter, so you'll be okay, and I'm quite sure you'll be happy with that. Okay. Now, the first one here is something called hydrocele. Okay, I'm quite sure you may have heard of this, maybe not. And hydrocele basically is just fluid that can actually build up around the testes and the spermatic cord. Okay. They do say that this is noticeable sometimes in infants, and it's also sometimes in pre-puberty boys. Okay, so infants and pre-puberty boys. They do catch it at that stage. Not so common, I would say, in an adult, unless that adult has some sort of primary infection or something like that. And then secondary hydrocele, but usually if it's just a primary hydrocele, it's usually in younger children. Okay, so they say in your book that what happens is that in the daytime, the scrotum is not enlarged, but as the night goes on, or when they're lying in bed, the scrotum gets larger and it fills up with fluid, and that fluid comes from the fluid from the abdominal cavity. Okay, so almost like, I don't want to say it's like in relationship to a hernia, but something along that line, okay, where it does fill up from that area. So again, this can be secondary to types of injury, also infection, sometimes radiation therapy could do this, or also if they have any type of testicular neoplasias. Okay, so the way they treat this is to just drain it, okay, surgically drain it, and that's easy enough, okay. So this is what it looks like. There's the fluid that just builds up and around over the testes.
Oh,
okay. Now the next one is what is called the spermatocele. So with the spermatocele, this is a cyst or a mass that's filled with sperm. So this is where it's pretty much, it looks like a hydrocele, so you really can't tell the difference if you were to look at the testes and see the enlargement. This is painless, just to let you know. And they're not sure what the cause is. They're not sure if it's maybe some sort of issue with flow, maybe for the epididymis or what have you. But in any event, this usually can go away, but if not, they can surgically just kind of remove that mass, okay? Because it's more so just like a flow and a backup type of situation, okay? But again, the cause, they don't know exactly what it is, although some people feel they have other reasons why this happens, okay? But they really don't know why it happens. Now, the next one here is testicular torsion. Okay, so what is this? This is when the spermatic cord gets twisted. And when the spermatic cord gets twisted, not only the spermatic cord is getting twisted, but also the blood vessels. So when the blood vessels and spermatic cord gets twisted, over time, this can now start to cause, obviously, ischemia. Okay? And you wouldn't want that, especially in that area, because after ischemia, that's going to lead to what? Death. Tissue death, very good, tissue death, or death, obviously, to the testicles. Okay? So this is what it looks like. Okay, and as you can see in that picture, that's really twisted. Okay, now they do have a couple of different. Well, they don't. I'm sorry, they don't really have to call so much of this, but they say that this can happen in pre-puberty boys. Okay, if you want to jot that down, this can happen in pre-puberty boys. So right before puberty. Now, clinical manifestations, severe pain in one testes, okay, swelling of the scrotum, nausea, vomiting. And the way they can actually identify this is through ultrasound, okay. I remember I had one of my friends, she went to school to be an ultrasound tech, and she came home and said, you know, I had to ultrasound somebody's testicles. You know, but that's what you have to do. And so, you know, and this is one of the reasons why, because you're able to see, okay, well, what is going on? Say, for example, even a hydrocele, okay, so you can see the fluid or the amount and so forth, okay, or even something like this, a torsion. So the way they treat this, they do say this is an emergency situation. Why? Because obviously we just talked about if the blood vessels are twisted like that, yes, this can lead to ischemia and lead to tissue death of the testicle. So they do something called a PEX, which is basically what they'll do is unsecure, I shouldn't say unsecure, but untwist the spermatic cord and then secure the testicles pretty much to the wall of the scrotum. And basically what they're looking for is to make sure that the spermatic cord does not roll up again. So I'm just trying to give you an example. I don't know what exactly, you know how you take something and it curls back up. So they're trying to make sure that it doesn't twist again. And so if it doesn't twist in about a 12-hour period, then they feel like, okay, then it's stable. If not, then that's not a good situation. Okay. They also say if the twisting happens more than a 24-hour period, the chances of that testicle being able to survive is not good. Okay, because
there was unknown cause?
Yes, they have an unknown cause. They're not sure why this happens. The only thing I can think of is probably trauma, but there's no type of bacterial microbial thing that can make this happen. The only thing I can think of is maybe trauma or just how the organs behave, pretty much. Okay, so that's that for testicular torsion. Now the next one is epididymitis. Epididymitis, you know where the epididymis is located. So this is the itis of it. So this is definitely going to be inflammation of the testicles. They do say that this comes from when there's a reflux of urine that actually can go back into that area. Or they say sometimes this can be from secondary to bacterial infections. And the bacterial infections that we're talking about here are most commonly the STDs. So the most common STDs like gonorrhea and chlamydia, okay, can also cause an itis in this area. So if we have an itis, one thing that you would definitely find is elevated white blood cells. So I would make sure you highlight that. That's important to know. The urine will be positive for that organism. Okay, so definitely if it is chlamydia, gonorrhea, whatever it is, it's going to show up positive. The scrotum's going to be large, red, tender. So remember all the signs of inflammation, pain, redness, swelling. Okay, they're going to have all of that. And then the best way to treat this is with antibiotics because most of the times these things are bacterial, and just rest. Okay. This next one here is something called Fournier's gangrene. Okay. And this one here I wasn't quite sure about, and I even had to ask the micro teacher about this, and she said that this can sometimes come from bacterial infections as well. But in your book they state that usually people that have Fournier's gangrene usually have a primary of diabetes. Sometimes people that are diabetics can have this, and also people that have alcoholism. Okay, people that are alcoholics. So diabetics and alcoholics. And diabetics and alcoholics, because what happens with these individuals, because of the disease process that they do go through, it does make them more susceptible for infection. Okay.
Because of, I'm sorry, say it one more time.
Yes, with diabetics and people that are alcoholics, because of the disease process that they do go through, it makes them more susceptible for infection. And so they can get infection, and the type of infection gets so bad that it will get sort of a gangrene. This is a gangrene situation. So this is a gangrenous necrosis to the scrotum. So when we have something that's gangrenous, okay, obviously we know that that tissue is dead. Okay, it's not working, or I should say not working, but it's not functioning. So they will have pain, swelling, fever, chills, and they could also have sepsis. Keep in mind that this type of infection can get systemic through the body. Okay, so they can go that route if it gets that bad. Okay. Now, the way to diagnose this, definitely history of physical, ultrasound, okay, which we talked about already, and that way you'll be able to actually get a visual of what's going on along with CAT scan and MRI. So, the good thing about this is that they can treat this by actually just cutting out the gangrenous portion. Draining, incision and draining the gangrenous portion. Because as you know, when we have something that's gangrene, what do they usually do to a gangrenous organ?
cut it off.
They cut it off. Okay, so thank God they don't have to have their testicles cut off. Okay, so they can just cut off or make an incision, drain the gangrenous area. Okay, because I guess the way the tissue is in that area, I would assume it's more like a wet gangrene. Okay, so they're probably able to drain it instead of just removing the whole organ. Okay, so and give them antibiotics. Okay, so that's that. You think this is fun? Wait till we get to the females. And I have to show you some pictures that's going to make you fall out. Okay. Now, neoplasias. Sometimes, it's not much to say about neoplasias of the testes, but sometimes males can get testicular cancer. Now, we all know that prostate cancer is a little higher on the totem pole, okay, than testicular cancer. But they do feel that testicular cancer can be, I want to say prevented, but what happens here is that just like females have breast cancer and you can do self-breast examinations, men can also do self-testicular examinations to see if there have been any masses or lumps or what have you. So they can do that as an early detection. Now, another thing is that obviously with most cancers there is no known etiology, but sometimes with this type they do feel that there is a known etiology of something called cryptorchidism. Cryptorchidism, just to let you know, is a term called hidden testes. So sometimes male babies are born and the testes do not descend. Okay, so you know, if you remember embryology and you know that males actually start out looking like females, okay? And then the testes actually start in the abdominal cavity, pelvic cavity, and then they descend down. So what happens here is that as they go through that process of descending, it doesn't descend completely, and so they will have what is called hidden testes. Now, they do believe that infants that are born with hidden testes or cryptorchidism, they have a high chance of having testicular cancer. Okay, so just to let you know, they do believe that in that situation. So the treatment here depends on the type of I shouldn't say the type of cancer, but it depends on pretty much the grading and staging and what happens here. So I'm not going to test you so much on, the different types of it, but just so you can get an understanding, just basic understanding what it is. Okay. Now, the next one here is benign prostatic hyperplasia, also known as, sometimes you hear the term benign prostatic hypertrophy. Okay. Now, this is BPH. BPH is very, very common. As you see here, seen in 80% of men, okay, over 60 years of age. They say the etiology is unknown, but they do believe that because of the aging process that occurs with males, that sometimes it changes the hormones, and it causes the hormones to just kind of make a hyperplasia of the cells, or I should say of the gland, the prostate gland, okay? So this is what they believe that happens with that, but they're really not sure. So, as you all know, most of you guys know this information already. So when a male has an enlarged prostate, what's the problem? Blockage of what? The urethra. Keep in mind that the urethra runs right through the prostate gland. The prostate gland actually is probably like the size of a walnut, and then it becomes larger like the size of a lemon. Okay? And so what will happen is when it gets that large, it can now compress on the urethra. If it compresses on the urethra, what types of signs and symptoms is this patient going to have?
Trouble urinating.
Trouble urinating.
UTI?
They can have UTI, yes. They can have UTI situation if it really gets more of a backup or, to that point. But keep in mind also, what else runs through the urethra that people sometimes forget?
Semen?
Very good. Semen, seminal fluid. So you're right. So they're actually going to have a decrease in urine flow, but it's not listed here, but they will also have a decrease in seminal fluid, okay? So your patient may tell you that, okay, and then you have to figure out, okay, well, maybe something's wrong with their prostate. I remember when I was in school, and believe it or not, because, I don't know, in chiropractic class, they made us do everything for whatever reason. But I actually did a prostate exam, not a real one, but on the simulated male. And so basically, and you guys will most likely do this too next term or the term after. But you have to go in and feel the prostate. Okay, and then what will happen is benign prostatic hypertrophy, the way the prostate feels is actually large all around. But then what will happen is if a person has prostate cancer, you'll feel sort of like a tumor on one side. Okay, so you're able to feel it. Okay.
When it comes to like the back, like you said, seminal fluid like decreases or backup, what would that present as? Painful, or is this just?
It won't be painful. It's just that your male patient may tell you, when I ejaculate, not much comes out.
Okay.
Or they may even tell you that when I ejaculate, the fluid is not white. It's almost clear. Because the prostate actually makes semen white, gives it that white color. So they may tell you that if the prostate, and even for prostate cancer as well, that may also happen. So, now, diagnostic testing, rectal exam, because this is how you can feel the prostate, bladder scanning, and they can also do some urinary tests to see what's going on.
God bless you.
God bless you. The way they treat this, they will give them alpha blockers, okay, to pretty much relax the muscle and not so much to decrease the hyperplasia, but to decrease the pressure and relax the muscle of the prostate gland, so it'll stop that squeezing on the urethra. And I'm not sure what microwave therapy is, to be honest. And I guess that sounds a little much in that area. And then needle ablation, which I'm sure they can just kind of go in and maybe just kind of decrease the area. And surgery. Okay, surgery, you know, they can go in and just reduce the size, and that's not a problem. Okay, so this is a picture here, nice picture showing you the BPH, how that is just now very enlarged and squeezing and causing an issue here. So as you said before about can they get infections? Yes. Okay, because here's the bladder, and what's happening is it's trying to release the urine to go down, but now it can't move anywhere. So is it a possibility to get a reflux? Yes. Okay, and that can definitely give them infection. Not only just bladder infection, but if it gets really bad, it can get up to the ureters and all that. So, and that's just another picture showing you the whole flow. Okay. Now, prostatitis. Prostatitis, excuse me, is an inflammation of the prostate gland. This is also quite common. They do believe, though, that this is definitely, well, I shouldn't say definitely, but mainly from bacterial infections. Okay, so mainly from bacterial infections. And what happens here is that bacterial infections can pretty much get inside or into that area in and around the prostate. So they do say that the roots of entry, I shouldn't say the roots of entry, well, kind of, is a reflux of urine. So reflux of urine, just like we saw with the person with BPH, can give them a prostatitis, that inflammation. And rectal invasion, okay, so in hematogenous, which I'll show you a picture in a second what we mean by that. So if you look at this picture here, bacteria from other sites can invade the bloodstream. So through bloodstream, this bacteria can now invade the prostate gland and just get there. We can also have maybe bacteria that's either in the bladder or kidneys, okay, that gets through the urinary system, gets down into the urethra, and then somehow gets into the prostate gland. Then we can also have maybe from direct extension from the rectum or also the lymph nodes in that area where bacteria in the rectum can get to the prostate gland, okay, because as you know, those organs are close. And then we can also have it coming up through the penis, in through the urethra, getting to the prostate gland itself.
But that one's pretty rare out of all of them, isn't it?
This one?
Yeah.
No.
No?
This one is a little more common because it's to the external environment.
I thought because it took a longer time to get through.
It could take a longer time, but it's also common, and to be honest, a lot of this is hygiene too.
Right.
Because sometimes fecal matter or bacteria can kind of get through and get up.
Or like a catheter.
Catheters, yes. Catheter is a very good example of that. That can get through and cause that inflammation and bacterial infection in that area. Okay, so because it is an itis, they will have fever and chills. Okay, so make sure you pay attention to the ones that's an itis. And note that they do have fever, chills, they do have elevated white blood cells and all the things that go along with an itis. Back pain, okay? Now, I told you this before, and keep in mind that sometimes, especially reproductive disorders, patients may say to you, oh, I have back pain. But then sometimes you may have to think, okay, well, let me ask questions that may have to do with the rest of their anatomy that's in that region, okay? Because a lot of things mimic back pain, and people think, okay, well, maybe just my back is hurting. But then once you start asking questions, well, do you have a frequency in urination? What's going on? You know, some other questions, then you'll figure out that it's maybe just much more than back pain, okay? So, rectal exam, tender swollen prostate. Okay, so pretty much like a feeling, pretty much of like a BPH where the whole prostate is just kind of swollen. And then they can also have this chronically as well. Okay, so for prostatitis, they will definitely have elevated white blood cells. You will also see bacteria because that is the cause of this situation. And treatment, antibiotics, and any anti-inflammatory meds to calm it down. Alpha blockers will actually cause a suppression of the muscle contraction of the prostate. Prostatic massage, which I don't know who would do that, and sit backs. Okay, so that is the treatment for that. Okay. Now, prostate cancer. Prostate cancer, not much to say about it. Actually, they don't have a lot of information here with it, but what they do have is that prostate cancer, as you can see, 95% of cases of adenocarcinoma, 35,000 deaths per year, 200,000 new cases annually. Prostate cancer is actually very high. It's actually one of the top of the list of cancers. When we talk about prostate cancer, breast cancer, and lung cancer, those are the top 3 of diagnosed cancers, and also the top 3 cancers that lead to death. Okay. From my understanding, just from knowledge of what I know, prostate cancer, if it's caught early enough, from my understanding, it can be treatable. But what happens is sometimes patients do have certain signs and symptoms that they think may be something else, or that they overlook, and then unfortunately by the time they go to the doctor, it's kind of far gone. So just like most cancers, the etiology is unknown, although definitely genetic factors and hormonal and diet. I had a student yesterday's class, quite interesting. We were talking about this, and I think it was testicular cancer. And he said that if he, I guess he asked a question, if he knows that there's cancer that runs in his family, I guess maybe testicular cancer, prostate cancer, should he have his testicles removed or have the prostate removed if he's done having children and he doesn't have to worry about that? Well, that's kind of, I don't know the details of what happens after having a surgery like that. Like, what are the outcomes? Can he still have proper function in that area? I don't know. But it's kind of like the situation with, I think it was Angelina Jolie, that she got a mastectomy because she knew that this could run in her family. So things like this, what will happen is people can get genetic testing done to see, okay, what are the chances of you having this? That type of testing, just to let you know, is very costly. But if you're that concerned about it, you can see, okay, well, what are your chances are getting this type of cancer? Because these things are, I shouldn't say that's the cause, but these things most of the time can contribute to genetics. Genetics really, really play a big factor in it. Okay, so grading and staging of this cancer, I'm not going to test you on it, but just know, just like any other cancer, depending on the level of grading and the level of staging, they have to get aggressive with it. Okay, so it just all depends on what it is. So the way they diagnose this, definitely rectal exam by feeling, as I told you, when they do that prostate exam, feeling to see is there a mass on the prostate. Also biopsy obviously will tell you the grading part of it, so you can look at the histology of the slide, okay, and look at the dysplasia that's going on. And then you can do what is called the PSA testing, which I'm sure you guys have heard of. And so this serum prostate specific antigen, this is definitely elevated or present in individuals that have prostate cancer, okay, this will definitely show up. And they can also do an ultrasound. So they say treatment here is watchful waiting in the beginning if they feel that it is sort of early stages, but then once they feel that something needs to be done, it can be surgery, radiation, chemo, whatever needs to be done, okay? And that's that for males. Isn't much. I cut down a lot of stuff with males. Okay with that. Now, for female disorders, we will talk about menstrual disorders. We will also go into uterine disorders, uterine dispositions, and inflammatory diseases, and also benign growths. Okay. So we will go through quite a bit. There's a little more involved with females. Okay, so the first thing we're going to go over, and I'm quite sure you've heard of this term before, amenorrhea. Okay, amenorrhea for menstruation, A meaning absent or no or none. Okay, so no menstruation. This can be caused by hormonal disturbances, sometimes stress, okay, as females know, and this can also be from sometimes neoplasias. Okay, so sometimes if a person has maybe an ovarian cancer or even sometimes an ovarian cyst or things like that, it can also maybe alter the menses. Okay, treatment is definitely paying attention to the underlying cause of it. Okay, and they do believe hormonal supplementation can also help with this. As you know, sometimes birth controls are used sometimes to get female cycle regular, okay, because sometimes when the hormone levels are dropped, okay, it can also cause this kind of situation. Now, they do say the primary causes coming from the hypothalamus could be anorexia nervosa, strenuous exercise, gonadotropin deficiency, and congenital defects or tumor. Now, let me talk about the first two. I had a roommate in college. She was an exercise freak. Okay, she would exercise like 2 times a day, and not only that, she really ate nothing. Okay, so she definitely was along the lines of sort of the anorexic type. And so, long story short, she was about in her 20s, and she hasn't had a menstruation in about 7 years. Okay. So what happens here is that when these individuals do go through, say, for example, not eating, getting proper nutrition, not only that, but exercising, and so what's going on is that this is altering their hormone levels. And so when you talk about the hypothalamus, what is the hypothalamus connected to? What system? Very good, endocrine. And what is released from the endocrine system that affects the reproductive? Not directly, indirectly, but there's another hormone before we have a release of estrogen. Not oxytocin. You're kind of in the right area around the pituitary. It's from the pituitary.
ADH?
Not ADH. Anterior pituitary. You guys talked about posterior pituitary. Anterior pituitary. I'm sorry, this is where the anatomy comes from.
No, but that we didn't know that.
I have a picture of my head.
I know, I see it.
I see it too.
LH and FSH. Remember that LH and FSH have a direct relationship to estrogen and progesterone reproductive hormone levels. If those levels are down, estrogen and progesterone is down. If those levels are up, estrogen and progesterone levels are up. Okay, so make sure you understand that there is a neural component to this. Very important to know. Well, here we go, pituitary. Okay, so pituitary, if they do have some sort of hypersecretion or hyposecretion, okay, in the pituitary gland, that can definitely offset these hormones that we know are the LH and FSH, which can cause these individuals to definitely have issues with amenorrhea.
So we'll say like athletes, people or women in the I would say the military, These are the type of people who are.
Yeah, when we're talking about, when I say strenuous exercise, I'm not talking about people that, like athletes.
Because that happened to some of us in college for softball.
Yeah, it can happen to athletes, but then when you train, you do train and you do have rest periods, but then we're talking about people that train and then they just keep going.
Olympians.
Yes, yes.
So does that mean the follicle stimulating hormone and the luteinizing hormone, it doesn't build the endometrium and the...
Right, so it doesn't keep, because it's not enough hormone that's being produced, because it actually suppresses the nervous system, that it doesn't maintain the lining of the uterus. Okay, so it doesn't maintain it, and actually you don't get the shed that you're supposed to, because the hormone levels are just not enough. Okay, so thyroid also can be part of this. So a person that is hypothyroid, this not only, as you know, with hypothyroid, everything is metabolically depressed, but this also depresses the nervous system, which in turn depresses everything else. Okay. So they also have more causes here: adrenal, ovarian, polycystic ovarian disease, which is also quite common. This can also cause females that have amenorrhea, and different situations with the vagina. So they give you a nice chart here, excuse me, that goes over primary and secondary amenorrhea. So I would please pay attention to that. Honestly, I haven't made up the test questions with this information yet, but I will make sure that the questions are geared just towards the PowerPoint. Okay, so nothing too crazy. So, secondary causes, same situation here, anorexia, strenuous exercise. But then they also have post-pill amenorrhea, not sure what that is. I don't know if they're talking about birth control pill. And then pituitary. Now, going with the birth control pill, let me just say this. As you know, with birth control pills, sometimes they can cause, if the hormone levels are not balanced, they can cause intermittent bleeding through cycles, and also sometimes they can really suppress the uterus to the point where you don't have a cycle. And as you know, some females may know that sometimes being on birth control pills for a long period of time, or depending on what type it is, can have a person not have a menstruation. Okay. That's not the healthiest thing in the world, because what happens is that with taking birth control pills, it's actually tricking your body to think that you're pregnant. And so what's the purpose, some females may know this in the class, what is the purpose of having your menstruation every month? To clean out the uterus for what?
Dead cells.
Not just it was for dead cells, but for what reason?
Prepare
for implantation of the fetus. Okay, so it's only in the event if you become pregnant that month. That's the only reason why you have menstruation. So it is important to make sure that the lining of the uterus is released. Okay, so that is a normal process. So thyroid again, adrenal for secondary, so it's pretty much the same situation here. Okay. Now, another type, or the next term we're going to go over is metrorrhagia. Okay, metrorrhagia. Metro meaning between, rhagia, bleeding. Okay, so this is bleeding between menstrual cycles. Causes here, slight bleeding in the endometrium from ovulation, that can happen. Sometimes polyps and cervical erosions. Okay, so sometimes there can be things that go on in the walls of the uterus and so forth that can just also cause this bleeding. And just like I said, birth control pills or estrogen therapy. Okay, most birth control pills have a high estrogen base, some progesterone, but the IUD has more progesterone than birth control pills, but most of them are estrogen based. Hypomenorrhea. This is deficiency in the amount of menstrual flow. The only thing they really say about this is the cause can be maybe hormones, or sometimes there can be just something that's occluding the obstruction of menstrual flow just to get out. Oligomenorrhea, or oligomenorrhea. This is infrequent menstruation. Cause is definitely from an endocrine hormonal type disorder. Okay, so if the hormones are off, this is also going to cause the menstrual cycle to be off. Okay, They don't have the treatment here, but most of the times the treatment for this is birth control pill. They do give some sort of hormone replacement, hormone therapy to try to get this under control. Menorrhagia is an increase in the amount of bleeding. This can come from a number of things. This can come from lesions in the reproductive organs. It can come from also a disease process, cancer. A lot of different disorders can just cause extra bleeding, so it just matters what it is. Now, dysfunctional uterine bleeding, they say that this is something that's not associated with any type of tumor, inflammation, but just some sort of dysfunction. And this is pretty much around the time of menarche, when you first start the menses, and then also around the menopause or premenopausal time. Now, let me say this about menopause, and I've seen this happen. Have you guys ever heard of a female getting pregnant around menopause? Yes, it can happen. Because what goes on at that time is the hormone levels are trying to get suppressed, okay, with the estrogen level, everything's just trying to get suppressed. But at the same time, it's sort of flip-floppy. So they will have sort of intermittent bleeding at that time, and it's a possibility that they still can get pregnant because they do have enough hormone levels possibly at that time to support fertilization. I remember one of my neighbors, she was almost in tears, okay, when she found out that she was pregnant and her youngest son was in college. Okay, so we're talking about starting all over again. Okay, so it can happen. Okay, so most of the times adolescents, but also yes, during menopause, as I told you, most of the times they do treat this with oral contraceptives, okay, but they can give them surgery if need be. Dysmenorrhea. Dysmenorrhea is painful menstruation. Primary, they say, can happen early on, right in the beginning of menses. And these individuals do have sharp, cramping, nausea, vomiting, diarrhea, all of this that kind of goes along with this. Now, they call this a disorder, but painful menstruation is pretty much cramps, okay? But sometimes females can have painful menstruation that can get really outrageous. I had a girlfriend, she would faint because that's how bad the pain was. So sometimes people can have an extreme pain. But what do you know that's cramping? What gives the cramping during menstruation?
Uterine contractions.
Very good. It's the uterine contraction. So the uterine contraction during that time to actually get the lining of the endometrium off will contract, contract, contract. And what does a muscle do? A muscle gets fatigued. So when the muscle gets fatigued, this gives a cramping, burning feeling. So that's the situation here. They call it a disorder. It's not really, to me, a disorder unless, I guess, it's
use it though.
really, really bad. But some people do have it. Really, really bad. Oh, I have one girlfriend. She plays up the PMS. You wouldn't believe it. It's just calm down. Okay. So, in any event, this can also be very painful if a person also has any type of pelvic lesions or adhesions. Even patients that have fibroids, okay, can also have this type of situation, which we'll go into in a second. So, treatment, prostaglandins, oral contraceptives, and then they can do surgery to kind of remove whatever the issue is, if there are adhesions. Now, we get to the fun stuff. Uterine prolapse. With uterine prolapse, what is a prolapse? Something that is produced, or I shouldn't say produced, or falls down out of its normal position. Okay. Now, how do women get this? A lot of people wonder. This most of the times comes from age, okay, because you know as we age, everything goes south, okay, and what happens, everything starts to weaken, and especially sometimes the ligaments in the pelvic cavity will weaken. Another thing that can happen that is a cause for this are women that also have multiple pregnancies, multiple births. So the more children you have, this also weakens the pelvic cavity and the ligaments in that area. So, although they say it can occur at any age, I used to work in a GYN office when I was in undergrad, and sadly enough, you would have these old ladies call and say, I see something coming out. And that's exactly the calls that I would get. And so unfortunately, sometimes the uterus can prolapse. If it's a full, complete prolapse, it can prolapse all the way through the vagina. Okay. So, causes, they say congenital defects, definitely pregnancy, childbirth, and also what they're not putting here is age. Okay, age is also a factor. So, here we go. Now, if you remember anatomy, the uterus is like this, and what happens is sometimes GYNs will say uterus, cervix, and vagina as if it's three different things, but it's not. The cervix is actually the lower part of the uterus, okay? So what you're seeing in this picture, and I know it's not a pleasant picture to look at, but what you're seeing in this picture is actually the uterus and the cervix, okay? So this is the uterus, the body of the uterus, and then that opening there, or that portion there, is the cervix. So, that can happen. So don't be surprised if you see it. You may see
Well,
it.
yeah, I'm gonna be surprised.
You may see it.
Oh.
It's actually, uterine prolapse is actually more common than you think.
What is the difference?
Especially females, and they have different levels, which I'm going to go over, but especially females that have a lot of children.
What about retroverted and introverted?
We're going to go over that next. So, with uterine prolapse, okay, first degree, second degree, and third degree, this all depends on the location, okay, and I'm going to show you some more pictures in a second. So, first degree is when the uterus is halfway between the vagina and the levels of the ischial spine, which is just sort of at the beginning, okay. Then the second degree is when the end of the cervix starts to protrude to the beginning, the introitus, right at the beginning of the opening of the vagina. And then the third degree is when you have the picture that I just showed you, the full body of the uterus along with the cervix that's outside. So, here's the position, first degree, second degree, and third degree. Okay. These pictures are in your book, so not the first picture I showed you, but it's a possibility I may put one of these pictures on the test. And then when we get to uterine displacements, I'm going to also put those pictures on the test, okay, because there's different displacements that can happen in the uterus. Now, there's a purpose for this. You guys got to do GYN rotations, so just to get you prepared. Yes?
Is the uterus being held by anything when it's out, or will it actually just leave?
If it is being held by anything, it's just like barely. Okay, so, and I'm going to show you how they treat it.
So it can actually just come out all the way?
It won't come out all the way. Oh my God, I'm just thinking that would be terrible. No, it won't come out all the way. It is still kind of held by but the ligaments just kind of stretch out, kind of like if you pull out a rubber band. So it's just a stretching, but it's not a complete avulsion, okay, where it'll just fall out. No.
You're like,
Yeah, that would be sad. Okay. So signs and symptoms obviously will depend on the severity, okay, of the situation, obviously. They will have fullness, obviously vaginal discomfort, discomfort walking, sitting, urinating. They may even have bleeding. Now the way they treat this is sometimes obviously with a full they may have to do a hysterectomy, because keep in mind once those ligaments stretched out, there's really no way to kind of get those ligaments back intact. But if it is, say like maybe a second degree, and I've actually seen them do this a lot in the office I used to work at, they would do pessaries, okay? And the pessary is almost like a cervical cap, where they'll just insert that and it just basically holds the uterus in place. So it just kind of holds it up. Now, just to give you an understanding, sometimes these pessaries have to be, they have to be fitted for them, and sometimes even have to get them changed, okay, just to make sure, because sometimes it does change, or your body may change according to it. So if they are a candidate for the pessary, they'll get that done, okay. Now, the next thing is retro displacement of the uterus. So we all know where the uterus, how it's placed actually in the body, normal anatomy. Now we're talking about a uterus that is probably tilted forward, tilted back, maybe flexed, okay? So a lot of different things can happen with the uterus. believe it or not, this is actually also very common, okay, just as much as uterine prolapse. And sometimes this can present an issue. Most of the times it's usually not an issue, but then sometimes it can be an issue during childbirth. Because if the uterus is flexed in an abnormal position, there's going to be an issue not only with the fetus growing, but what will happen is when it's time for labor and delivery and time to push the baby out, yes, there's going to be an issue because the uterus is not in its proper position. So, and sometimes this type of situation can kind of cause breech babies because the uterus is not in its correct position. So, causes, congenital pregnancy, childbirth, and we do have 5 positions that we're going to go over. Okay. Signs and symptoms, they can have pelvic pain and pressure, but most of the times females don't even know they have a retroverted or introverted uterus until they go to the GYN and they say, oh, do you know your uterus is whatever. Okay, so they usually don't know. But sometimes they can have dysmenorrhea, so they can have difficulty in menstruation. Dyspareunia, I think I'm pronouncing that correctly, that is painful sex. That's just a medical term for painful sex. And the treatment here is usually no treatment, but if they have to, they can do surgery or probably a pessary for these individuals. So, hope you can see this in the back. Uterus is normally, let's say, this position, okay? Where, as you know, the uterus lies sort of like this, and it's at pretty much like a right angle to the vagina. Does everybody know that? Okay, so now we're going to look at the uterus in different positions that are abnormal. So this is what we call an anteverted uterus. Anteverted meaning that the entire uterus just goes towards the anterior position of the body and is actually sort of pushing up or close against the bladder. So if you had a pregnant female that had that, obviously they're going to have a lot of issues with pressure on the bladder, among other things. Mid-position, this one here, it's almost in its right position, but it almost looks like it's distended a little bit from the vagina. It looks pushed out. So I'm not sure the whole thing with mid-position. Now, anti-flex. So the anti-flex uterus, as you can see, is in an anteverted position, but the body of the uterus is flexed. Okay? Now, if you look at that, that would definitely probably give a lot of complications with pregnancy and possibly labor and delivery, okay, if it stays in that position. Then look at retroflex. Retroflex is now that it's in its retroverted position, meaning that it's pushing now towards the rectum, and not only that, the body is flexed over onto the rectum, okay, and sometimes it may even touch the rectum. And then here's retroverted. Okay, so those are the 5 positions. Again, it's a possibility I may put one of these positions on the test as I have to add in some more pictures and stuff for you guys, and especially if you were to ever see this, you got to know which position.
She asked what type I had. I said
Retroverted, yeah. And it's very common. It's very, very common. And not to say that if you do have a displacement that you will have, complications or anything like that. But it's just good to know because any event, certain things you need to know. Now, we got some other fun stuff. Cystocele and rectocele. Cystocele is a protrusion of the urinary bladder and it pushes out through the vagina. Okay. Now, people wonder how in the heck did that happen? Okay. So what happens is that the vaginal wall it's sturdy, but it's not that thick. Okay. So what will happen is that almost like kind of like a herniation, if you want to say that, where the wall just kind of weakens, and so the bladder will actually start to protrude to the anterior portion of the vagina. They say the causes here is usually injury. They say injury during childbirth, but just to be honest, it also is during pregnancy. So like this can happen after pregnancy or multiple pregnancies because everything just kind of gets very weak in that area, just like a prolapse. So it's sort of a prolapse situation, but just with the bladder, okay? Aging, obesity. and heavy lifting. And that is true. My mom would always tell me, don't lift heavy stuff, and I would always lift heavy things. Yeah. So, what happens here is that sometimes people with cystocele, they may have symptoms and they may not, depending on the severity of the cystocele. So, vaginal pressure, fullness, dysuria, so difficulty urinating, back pain can also be associated with this. The way they treat this is actually surgery, okay, to repair and to actually push the bladder up. And I actually did some research on the surgery, and basically what they have to do is they're taking the bladder to push it up, but you also have to run a catheter on that patient to make sure that they can have urine flow while the bladder, I guess, is trying to get in its proper position, or when they do, because it's more like a reconstructive surgery that has to be done. So that's that. This is what it looks like. One thing I want you to pay attention to is that the cystocele is on the anterior portion, or if you want to say the superior portion of the vagina. The next thing we're going to look at is a rectocele, was actually below. Okay, so this one is above or anterior.
Or she said superior,
Yeah. So what'll happen here is that this is they call it anterior portion of the vagina, but when you look at it, it's really it's superior. Okay. During GYN exams, this can definitely be seen during examination. Okay, and it just, you'll see the bulge, almost like as if you're looking at a prolapse. Okay.
Well, where would you distinguish between this and maybe a tumor?
That's a good question. I don't know how common vaginal tumors are. This is coming from the vagina. I'm not sure how common vaginal tumors are.
Cervical or something, anything like that. Would you?
Well,
because it's pushing forward.
Because it's in the vagina, a vaginal tumor I think would be more outside. I mean, unless it's that large, it'll protrude out.
Yeah.
But I think it would stay more inside the wall, or inside where you won't be able to see it unless maybe like a transvaginal ultrasound or something like that. But these type of things do protrude because of weakening. So they'll come out during the weakening. That's just like saying if someone had a rectal tumor, it's going to come out. That's kind of rare. I don't know how that I don't know if that happens like that. So rectocele, also known as prostacele, this is a protrusion of the rectum. Okay, now coming through the vagina. And so it comes through the vagina in the posterior vagina or the inferior portion. Okay, and again, the causes are coming from a weakening of those ligaments, okay, in that area. Can be childbirth, multiparity, definitely multiple pregnancies. Keep in mind, I have a patient that she has 7 or 8 children. Well, 7 or 8 children. And she had to have that kind of surgery done twice, okay, for the, and I don't know why she continued to. Some people, they just want to have a basketball team. So, in any event, she would keep having children, but what happened, she had to have that surgery because she did have a lot of prolapse, okay? And so, this is just so you can explain, just explain, because when you may have patients that have multiple pregnancies, they have a lot of children, these kind of things are definitely common, okay? So, and then they have your obesity. I forgot to talk about that. Obesity. Obesity, why? Why obesity?
So much weight.
Weight and pressure. Too much weight and pressure, just like pregnancy. Okay, too much weight and pressure. So symptoms depends on the severity. Constipation, as you can imagine, because the rectum is now in a different position. Painful bowel evacuation, and definitely painful intercourse. Okay.
So the rectocele has nothing to do with pregnancy, but urine prolapse, or uterine prolapse.
Well, no, this has to do with pregnancy too.
So can I put causes on there?
Yeah, both are pregnancy. Both are pregnancy.
Oh, I didn't even see that. Okay, sorry.
Both are pregnancy. Pregnancy for rectocele, cystocele, and even uterine prolapse. Okay, they're pregnancy, multiple pregnancies, I should say, are causes. Okay, so This one is towards the bottom. Okay, so whereas the cystocele was towards the top, okay, this is at the bottom. Okay, so I'm tired of looking at pictures. That's about as gross as it's gonna get.
Oh, that's fine.
It's not
Very
actual,
chill.
real stuff.
Your book has some other pictures. Now, do you guys want to take a break, or you want me to keep going?
Keep going. We get out early.
No, well, we're gonna probably be done early anyway because I don't have much material to go over. So let's take a break. Keep in mind, I do have to review. The review's not gonna take that long, but let's just take a quick break. We'll finish up with female reproductive.
I need to go like stretch out pretty short.